In Chapter 11, we'll talk about malignant disorders of white blood cells. So some of the malignant disorders of white blood cells include the leukemias and lymphomas. Leukemias are circulating tumors that primarily involve blood and bone marrow, whereas lymphomas tend to localize in lymph, hence the name lymphoma, and it's often disseminated to other sites when it's diagnosed. Now, this is differentiated from plasma cell myeloma because it's malignant, not just a tumor, but it's malignant, and it's a transformation of B plasma cells. So it's going to produce antibodies, but it likes to form localized tumors and bony structures. So you're going to see how, although it's a plasma cell or lymphocyte, you're not going to find it necessarily as often in lymph. You're going to see it aggregate and form bony tumors. Now, typical signs and symptoms of leukemias and lymphomas include malaise, weakness, unexplained fever and night sweats, recurrent infections, enlarged or non-tender lymph nodes, which we call lymphadenopathy, or lymphoma in some leukemias, very high total white blood cell count, and the presence of abnormal cell types. So it turns out that there are two main cell lines in our red bone marrow. All of our red bone marrow cells, so all of the blood cells that come from red bone marrow, they're all derived from one type of stem cell called the hemocytoblast. Now this hemocytoblast can differentiate into two main stem cell lines. We got lymphoid stem cells and myeloid stem cells. The lymphoid stem cell line gives rise to natural killer cells, B cells, and T cells. So these are more likely to give rise to the lymphomas because they come from lymphoid stem cells. Whereas the myeloid stem cell line gives rise to all of the rest of your leukocytes, as well as red blood cells and cells that make platelets. So the leukemias are more likely to come from the myeloid stem cell line, and therefore be tumors or growths of neutrophils, monocytes, red blood cells, or megakaryocytes, which give rise to platelets. So for the lymphoid stem cell line, what we find then is that tumors of natural killer cells can cause natural killer cell leukemia lymphoma, or B cell leukemia lymphomas, or T cell leukemia lymphomas. And so remember, the major difference between leukemias and lymphomas here is not just where the stem cell line is affected, but also where these cells are localized. So remember, the leukemias are more often going to be found in blood and bone marrow, whereas the lymphomas are going to be more often localized to lymph or other distant tissues. So, how do myeloid and lymphoid neoplasms come about? Like, what causes these leukemias and lymphomas? Well, some possible causes of this could be viruses, and there are some viruses that cause leukemias. And it could also be due to radiation exposure, because this radiation could induce mutations that lead to basically cancer of the myeloid and lymphoid stem cell lines. It could be due to chemical exposure, reduction or alteration in normal hematopoiesis, and sometimes it's heritable. There are some genetic disorders where it's a heritable form of myeloid or lymphoid neoplasms or leukemias and lymphomas. Now, the most common clinical manifestation of hematologic neoplasms we call leukopenia. And so leukopenia results in lymphadenopathy, or basically swollen lymph nodes. And you're going to see joint swelling and pain, weight loss, anorexia, hepatosplenomegaly, because with this increase in the number of cells, your liver and spleen try to break down this increase in the number of leukocytes. Now, what can also result from this is anemia, because with the excessive loss of red blood cells, or maybe malformed red blood cells, it can lead to anemia, which is basically a decrease in oxygen carrying capacity within blood. So with this, you're going to see pallor, fatigue, malaise, shortness of breath, and decreased activity tolerance. What can also result, you guys, is thrombocytopenia, which is where you have a platelet count below 20,000 cells per microliter, so low blood platelets. This can lead to petechia, which are kind of like pinpoint bruising on the skin. It can lead to easily bruising in individuals that suffer from thrombocytopenia. Bleeding gums, because it's difficult to stop wounds from bleeding. Occult hematuria, so you can sometimes find blood in urine, or retinal hemorrhages, which can lead to ocular disturbance. Now, the principal treatment for leukemias and lymphomas relates to a combination of chemotherapy and removing those malignant cells. So chemotherapy can be used to decrease the rate of cell division, but also removing any kind of malignancy if it exists. So if you can localize the site of malignancy, removing those malignant cells is most effective in conjunction with chemotherapy. What can also be effective too is once you've removed those malignant cells, you might need to replace bone marrow. And so in this sense, you might need some stem cell transplants to rescue and restore proper bone marrow function. Because part of removing these malignant cells could involve killing off all of someone's red bone marrow, and therefore you would need to reintroduce stem cells back into that individual. Now there's two major forms of stem cell transplant here. We have allogenic and autologous. Allogenic, allo means similar and genic means genes. So allogenic stem cell transplants are where we get stem cells from a close donor or match. So an individual who has a similar major histocompatibility complex as you would be a good candidate for an allogenic bone marrow transplant. Now an autologous stem cell transplant or where you get stem cells from that same patient. So prior to radiation therapy and chemotherapy, you can harvest stem cells from the patient, store those stem cells, and then after the patient's undergone radiation therapy, you can give their own stem cells back to the same patient, and we call that an autologous transplant. Now, radiation and tissue-specific drug therapy can be indicated in some cases. Now, in terms of management of complications, anemia can result, and it's a common complication of leukemia and chemotherapy, because suppressed red blood cell production can limit the size and shape of red blood cells and also limit the abundance of red blood cells. So the way that this is managed, the way that anemia is managed, is that you can administer the hormone erythropoietin as well as other growth factors. And erythropoietin, if you all remember, is a hormone that stimulates red blood cell growth. You can also have red blood cell transfusion, where you can just temporarily sort of administer red blood cells into someone's body, and also prevent any bleeding episodes, and therefore reduce or diminish excessive loss of red blood cells. Now, management of thrombocytopenia, which is platelet deficiency, can be achieved by frozen plasma, so actually just delivering plasma to someone's body, also delivering platelets, protecting an individual from trauma, so making sure that they don't have any cuts or bruises, that way they don't lose too many platelets, and in this case they're going to need to have activity restrictions, that way it diminishes the risk of any potential trauma. Pain is a common complication as well, and most commonly involves bones and joints. Now, the reason why you find pain in bones and joints is that from that thrombocytopenia, people's joints are more likely to have blood accumulate within them. That can lead to swelling and pain as a complication of that loss of platelets. Now, bones can be painful as well from erythropoietin administration, because too much erythropoietin can lead to overgrowth of red bone marrow, which can start to place pressure on the bones from the inside, and that can be painful. Now, this pressure can result from infiltration, accumulation of neoplastic cells as well. You get hematoarthrosis, or bleeding in joints from the thrombocytopenia. Other painful procedures like bone marrow biopsy can lead to pain, as well as nausea and mouth pain from chemotherapy, because chemotherapeutic drugs limit the growth of cells. They prevent cell division. Well, if you think about tissues in your body that require pretty rapid cell division, the mouth is one of those, and skin is another. And so, as well as the GI tract, so this can lead to stomatitis, or basically mouth pain from ulceration or sores that can accumulate as a consequence of chemotherapy. Now, we'll next talk about myeloid neoplasms. And myeloid neoplasms result from transformation and proliferation of precursor stem cells in bone marrow. Now, what we see here with the myeloid neoplasm is that the offspring of abnormal stem cells clone and build up in bone marrow, and they're released into circulation. So what you find then is that these myeloid neoplasms can lead to cells that can accumulate not just in bone, but also in the bloodstream. And you can identify these myeloid neoplasms by just looking at the types of cells you find in blood. Now, these abnormal stem cells are multipotent, which can cause an overproduction of more than one cell type. So with myeloid neoplasms, you typically don't just see one specific type of cell accumulating. It's typically multiple types of cells that result in like a myeloproliferative disease. And often these cells are functional, but have odd appearances, like odd morphologies. Now, some common myeloproliferative diseases would be things like chronic myeloid leukemia, or CML, and this is a cancer of granulocytes. Polycythemia vera, or PV, is a cancer of red blood cells, and essential thrombocytopenia is a cancer of platelets. Now, if y'all remember, the granulocytes, red blood cells, and platelets all result from the myeloid stem cell line, and so that's why we call this a myeloid neoplasm. Now, this differs from the lymphoid neoplasms because these are malignancies of the lymphoid stem cell line. If you remember, the lymphoid stem cells give rise to B, T, and natural killer cells. Remember, leukemias are going to be where these cells are present in blood and bone marrow, and lymphomas are going to be where these cells are localized to lymphoid tissues, like being in lymph nodes, spleen, that kind of stuff. Lymphoid neoplasms are defined by the location and the consequence of the disease stage. Now, there's a World Health Organization classification that uses cell type and not necessarily where the cells are located in order to classify what specific type of lymphoid neoplasm is present. Now, one type of lymphoid neoplasm we'll talk about is the hairy cell leukemia. Now, hairy cell leukemia is going to be more rare, but it's a chronic type of leukemia. It affects about 2% of adult leukemia, but is highly treatable. The median age of presentation is 55 years of age, and it usually affects males to females 5 to 1. Now, with the hairy cell leukemia, it's a B cell phenotype, so this is a cancer of B cells. And what you find here are peculiar cells with hair-like projections. That's why they're called hairy cell leukemia on the surface. And so it's identifiable through microscopy. Now, plasma cell myeloma, also called multiple myeloma, is a malignant disorder of mature antibody-secreting B lymphocytes. And so, because you're getting proliferation of B lymphocytes, you're also going to get overproduction of antibodies. Now, it occurs almost exclusively in adults, usually over age 40 years of age, but the median age of plasma cell myeloma or multiple myeloma is 65 years of age, and it typically affects men more than women. Hodgkin's disease represents about 30% of the malignant lymphomas and occurs across the lifespan. Most cases are between 20 and 40 years of age, and you have a higher incidence in males. Males also have a worse prognosis from Hodgkin's disease. And the overall 5-year survival rate for all stages of Hodgkin's disease is actually 85%. So the 5-year survival rate is fairly high. So it seems to be a fairly treatable disease. Now, what we find here is that Hodgkin's disease is characterized as a malignancy of B cells that accumulate in lymph nodes. Now, it's specifically characterizable by the presence of what we call Reed-Sternberg cells, and these are identifiable based on their appearance and genotype. Now, it's malignant, but the growth and spread is in a predictable way. In that way, it's more treatable because you can know where it's going to spread next. Now, what's convenient about Hodgkin's disease is that the metastases are going to be along contiguous pathways, which means if you find it in one lymph node, you could expect that it's going to end up in the next contiguous lymph node. So downstream of that lymph node will be the next metastasis. It typically won't jump around the body, which makes it more difficult to treat, or more easy to treat. So you'll find that if you find Reed-Sternberg cells in a lymph node biopsy of a lower limb, you'll find then that the metastases will spread along a contiguous pathway, which is what you can see here. And it won't jump along to other pathways. And so that way they're all linked up and not necessarily spread sort of randomly throughout tissues of your body. Now, the clinical manifestations and pathogenesis of Hodgkin's disease is that it's believed to be caused by exposure to Epstein-Barr virus, or EBV virus. This is in the herpes virus family, and it actually is what may transform these Reed-Sternberg cells, and it seems to be important in the pathogenesis of Hodgkin's disease. So what's interesting then is that Hodgkin's disease seems to be exacerbated by a virus. And so in some way, you can kind of think about this as being a virally transmitted form of leukemia. Now, it's usually present in a single node or localized node chain, and these inflammatory cells can accumulate within a particular node, and these Reed-Sternberg cells will only constitute about 2% of the cells that you find in a lymph node tumor. Now, other types of lymphomas we call non-Hodgkin's lymphomas, and this includes B cell, T cell, and natural killer cell lymphomas. They don't have Reed-Sternberg cells, and this is what differentiates the non-Hodgkin's lymphomas from the Hodgkin's lymphomas. The majority of these arise from lymph nodes, and they can arise in any lymphoid tissue. And lymphoid tissues include things like your tonsils, your lymph nodes, your spleen, Peyer's patches, appendix, any of those. This is typically a disease of older adults. Males are somewhat at a higher risk than females, and the incidence seems to be increasing, especially in AIDS populations. So it seems to be exacerbated by HIV. But most of these arise from B cells, T cells, and natural killer cells. That's why it's a lymphoma, because it affects lymphocytes. Now, the pathogenesis and clinical manifestations of non-Hodgkin's lymphoma is that you typically find painless lymphadenopathy, fever, night sweats, weight loss, malaise, and pruritus, or itching of skin. It may present with infiltrative disease of skin, GI tract, bone, or bone marrow. So these cells may start to infiltrate other tissues, not just the lymphoid tissues. The complications of non-Hodgkin's lymphoma include superior vena cava obstruction, where growing massive cells can actually obstruct this large vein going back to your heart, or even spinal cord compression, where due to bone infiltration, these cells can start to grow and compress in the spinal cord, leading to other complications. So infection, bone metastases, and joint effusions can all be complications of non-Hodgkin's lymphoma.